talk, and there's going to be some information that overlaps. There is some involvement with like the upper airway, right, in terms of how your GI system functions. But first and foremost, we'll talk a little bit about anatomy before we jump into any kind of pathologies that we're going to discuss. So, who can tell me the different pieces of the GI system?
The mouth.
The mouth, that's a good one. Give me some more. What else?
Stomach.
Stomach, what else? Yeah, what else? Hmm? Bowel? 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 How many parts of the bowel? How many parts of it?
3 parts of the small intestine.
So let's start right at top, right? Because we want to, and the reason that I want to do this is, and I'm going to emphasize this heavily. Your alimentary canal, your GI system, starts from here to there, right? So from top to bottom. And why I'm saying that is you're going to have different disease pathologies, and you think, oh, I expect to see X only in X place. For instance, like Crohn's or diverticulitis. A lot of people think diverticulitis only down here. But things that affect you down here can also affect you up here. Okay? So something to keep in the back of your mind. So let's start at the top. What's up here? What?
Nothing.
Doesn't seem like nothing.
I can't tell you.
Fair enough. We'll leave it at that. Alright, so what's up here? Your all of your body. You, and you by association. So, alright, what's here?
Salivary glands.
Well, your mouth, right? So what's in your mouth? Your I'm not doing this forever. Yeah, and then we have what else? Teeth, yeah. Because these are all parts of the system, right? So then moving backwards, what's back here? We talked about it in respiratory. Right, so we have our oropharynx, right? And then that goes down. What's that structure that separates the trachea from the and then for the GI part of it, we go down to what?
Esophagus.
Alright, and your esophagus goes down into the right? From the stomach, we go down over to the right, and your duodenum's connected to what? Now, what about on the sides? What helps? What's plugged in? So you have gallbladder, and then what else? Pancreas, right? So then moving down, we have duodenum. We talked about our accessory friends over there, and the liver does play into the system a little bit, right? A little bit, a lot of it. Some cultures believed in the past that the liver was more important than the heart. So your liver does a lot for you. So moving down to your small intestines, past the jejunum is the Oh, we did duodenum, right? And then we went to the and then down through, and then what's the port between the small intestine and the large intestine? The little porthole. There's a valve, right? Right. So that dumps in, and that's where we can see a lot of issues with obstruction. That's a small space. Connected to that portion of the colon is what accessory structure that we often remove. And we'll know that as well. And then we're going up. How many segments of large bowel do we have?
3.
What are they?
Ascending chambers.
And then we go all the way around to the we're in the colon. And then before the rectum, there's the well, that's in there, but what's that space that's right behind your rectum? It's the rectal vault. AKA your prison wallet. Anyway.
What is this vault?
Huh? What is this vault you speak of? It's just an open space, right? So when you think about the anatomy of a rectal sphincter, that's really, this is awful. That's really the tightest part. And then behind it, it actually opens up. So for instance, when we use things like Flexi Seals or Zazzies or whatever we call them, when we get them through the initial sphincter, we actually have to blow a balloon up to anchor it in there. Okay? All right. Any questions about anatomy? I feel like we understand the working pieces a little bit. Okay. So some things we're going to cover will be abdominal hernias, specifically hiatal hernias, intestinal obstructions, inflammatory disorders, and you're going to see a couple themes, and one of them is inflammation. What effect does chronic inflammation have? And I'll tell you from personal experience, after I went through nursing school, I really took things like diverticulitis and Crohn's disease for granted. I was like, whatever, a little diarrhea. No. It's not just a little diarrhea. Very bad. Very, very bad. Colorectal cancers, I'm not going to hit cancer hard here. We'll talk about it in terms of, because GI cancers do, I don't know. They have a wide implications on the whole system, and we'll talk about why that's important. We'll talk about supplemental parenteral nutrition. So first we'll talk about kind of some assessment portions of the oral cavity / pharynx. And some words you should know. There's some words you should know. Xerostomia, you should be familiar with that. That is a practical term you'll see in practice, but also at the inflex level. Xerostomia. Okay. Painful lesions in the mouth, we'll talk more about those. Difficulty eating, what's that? Some of my clinical folks might be able to talk about the nuances of what it means to not eat. Can you talk about that? Katrina, this is like a full answer. Yeah. Is it as simple as it sounds?
No.
Can you just say, if you came and told me, hey, I'm having trouble eating, can I say, Katrina has dysphagia? Yeah. Yeah, there's a lot of muscles that go into very simple things we take for granted, right? So a lot of people will throw around the term, say, dysphagia. It's something we talked about briefly in clinical. Dysphagia has a lot of implications. I mean, it could mean something neuro-related. It could mean that there's a mechanical obstruction. You know, it has all these different components that can be driving it. So this is why we have to understand the anatomy well enough so that we know what to anticipate. So difficulty eating, xerostomia. Can anyone define that word for me? You're like this guy. This guy can okay. So xerostomia. What kind of things might cause it? What kind of medications? What patients will often, what is maybe the most common medication you'll see patients get that can cause this? Marijuana. Not a bad answer. So, with breathing treatments, right? You can get dried out from those things. And also bleeding. I will say this. Being able to identify bleeding in the upper oral cavity is pretty important. Something you need to be able to catch if you see it. So, oral cavity and pharynx disorders, stomatitis. Who knows what stomatitis is?
Infection of an opening.
That's a very broad. I'll give it to you. I'll give you quarter credit. So, stoma meaning what? Say loud.
An opening.
Okay, and itis. Basically, yeah. Contrary to popular belief, it is not inflammation of the stoma, but it can be. Anyway. So we need to be able to look for signs of infections, things like gingivitis. What's gingivitis? What's the gingiva? Right, and why is that important?
They hold your teeth.
Sure. Tell me, clinically, because I can tell you for 80% of my nursing career, if I looked in someone's mouth and their gums looked weird, I'd be like, okay, and then just move on. But it actually does have some clinical implications. If I have a patient and they smile for me and then I go, oh, it seems like your gums are really inflamed and overgrown. What drug might I suspect that they take? Huh? There's a lot of neuroleptic anti-seizure drugs that can cause gum issues. So it's something that when you see a change in this, even though you might not be able to readily identify what's causing it, the ability to identify that something is out of the normal is important. Leukoplakia, who knows what that is? Leuko means white, right? Let's just say white. Plakia, plaque. White patches. And I'll show you some pictures of it, it's awful. So the key for the leukoplakia is that it's not something that can be removed. You know, if you have a patient, and you're like, I wonder what this stuff is in your mouth, and you try and clean your mouth, it disappears, great. If it doesn't, yikes. Signs of mechanical trauma and systemic disease, and then aphthous ulcers. Who knows what that means? No. You seem like you know.
No, I have this white patch on my tooth, so that's.
Can we save the consults for after class?
Yeah.
So that's a canker sore.
No, that is not a canker.
Dude,
Oh,
your
no.
tooth is gonna fall out. 100%. So, I will tell you this as a form of transparency. Unless you work for an ENT, a lot of these words, you need to remember them for the NCLEX, but after this, I've never heard the word leukoplakia in practice. I've never heard someone call an aphthous ulcer. I've even worked, one of my PAs I work for, actually originally specialized in dermatology, and I've never heard her use these words either. But, know them for the test. So, here we can see examples of a canker type sore. And then on the right side, you see a cold sore from HSV type 1. What is HSV? And why do I care what type it is?
One is the mouth and two is down below.
That's good. So can the same one be in both places?
Yeah. Yes.
Why? This is an important question. But why? Because, and I'll tell you why. I won't tell you why, but I'll tell you the reasoning is that there's a lot of people who will Google this, because I've had this question a ton of times, and then they're like, but it shouldn't be, it should not be, from what you read. But if you understand your anatomy, you understand why it can be. So why can't it be? You look like you have an answer. Come on, help me out.
Well, I don't
You
know,
can do this.
I'm feeling like I don't, but,
What are we doing?
I'm gonna go on a, guess, just the same kind of tissue.
Yes.
epithelial mucous membrane.
Same type of tissue. Your crotch and your mouth is the same type of tissue. That is important. It's a mucous membrane on both sides, right? So, and the reason I'm driving that home is birds of a feather can flock together.
It's like the same with HPV, right?
Right. The gonorrhea birds fly with other gonorrhea birds. Okay?
So, are type 1 and type 2 HSV, like, are they like if you look at them microscopically, they are different viruses?
You know what class you're in right now? I'm just kidding. We're not talking about that.
So, because
Yes, they have different histologic features.
Okay.
Yeah.
Because I was thinking if they can infect both places, wouldn't they just be the same virus? But if they're under the microscope.
Yeah, so, and I'll expand a little bit just to eliminate a little confusion. There's HSV type 1, which is what everyone essentially has. Like when they look at the data, there's 80% of the population is asymptomatically infected, and chances are everyone will have it at some point. Same thing with HPV, which we're trying to get ahead of. Now granted, there's a lot of things about HPV we don't understand because we don't have good longitudinal data. But point being is that type 1, you're like, okay, just about everyone has it, it's whatever. Type 2 is one that can make its way into your central nervous system. And that's why when you have a patient who has meningitis, and this is something that will come up in neuro, when you have a patient who has meningitis, you want to make sure it's not HSV meningitis. Okay? All right, oral pharyngeal cancers are typically squamous cell type cancers, and they have the prevalence per side. Welcome back. We just got done talking about birds.
Pay no attention to the lady behind the curtain.
Birds.
You're talking about birds and GI?
Birds, right?
They flock together.
They do flock together. can I full screen it again?
Oh, yes, you can.
Okay, alright, so, let's talk mouth pharynx. So you typically see cancers more like here than more up here, right? So cancer risk factors, we're gonna beat these into the ground because you're gonna see them a ton. Smoking, 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 smoking. Smoke with tobacco, alcohol intake. The real key word here is chronic irritation. Anything that's chronically irritating, chronically inflaming, and we'll talk about this more in cancer as well. This chronic irritation is what activates oncogenes in a certain place. So whenever we add things to the mix, like radiation from smoking, irritation from alcohol, all of these different things can precipitate this. And these are more common in men. What's that?
Like irritation, could that be like, is that spicy food count as irritation?
So, and the reason being is that spicy food, while it does cause irritation, actually causes more of a allergic type reaction in your body, so it's not quite the same. Oropharyngeal cancer assessments. The big one I'll drive home here is painless lesion or ulcer that doesn't heal. If you have a patient who's like, I have a thing in my mouth, I've had it there forever. It doesn't really hurt. And see, that's the insidious part about this, is that there's so many of these things that are either asymptomatic or minimally symptomatic to the point where no one thinks they need to get it checked, right? And then by the time they're like, oh, you know, I feel like my balance is off, and then you scan their head and they have metastatic cancer in their brain. So, painless lesions, wink wink, leukoplakia, wink 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 wink, Kaposi sarcoma, who knows what that is? Mark knows.
We'll talk about it in the HIV and AIDS section.
Thank you. Yeah. Yeah, so something you'll see in HIV/AIDS patients. You can see it in cancer patients as well. Lumps, bumps, unexplained bruises can be tumors, lymphomas, MLA, ALA, ALC, all these different kinds. Loose teeth. Now, late symptoms, dysphagia, anorexia, weight loss, pain, hoarseness, and large lymph nodes. The ones I'll draw to your attention to are dysphagia, and I'll draw it to you because it's so vague, and it can mean a lot of things. Anorexia and weight loss. Hone in on those. Unexplained weight loss and anorexia without anything else makes you think, there could be an issue going on there. Pain, hoarseness specifically, and we talked a little bit about this in respiratory. If you have a mass or something, changes to your voice are very indicative that something is in that zone, so your voice shouldn't just change past puberty or without obvious trauma. Who can guess what that is? Yeah, that's it. Yeah. And then here we can see a little bit of discoloration in the roof of the mouth, which is a good sign. When you have invasive cancers of the head and neck, things can get a little cray-cray.
I had a friend who chewed a lot of tobacco, and that's what his mouth was like. And then he quit.
But was he cool? So, oropharyngeal cancer diagnostic testing, obviously physical exam, you're gonna hear that every time, all the time, forever. Biopsy is really the definitive measure. If you see something, you gotta get a tissue sample of it and see exactly what it is. Cytology smear, a lot of people don't know that these are separate, and this is something that we do, especially in brain cancer, we do something called flow cytology, which is separate from the biopsy, which tells us a little bit more about what we've picked up. Swallowing studies, this isn't necessarily a diagnostic test for cancer, say, but anything that's affecting your swallow, you're probably gonna get CT or a modified Barrington, some kind. Staging may require CT scan, MRI, or PET scan. What's a PET scan?
Positive emission.
What do we use it for?
definition from off the eighth grade.
What do we use it for? Hmm? Yell it out. It says right there. We use it for cancer. Like, most of the time that you're gonna see it, it's a kind of a full body scan that involves the use of different radioisotopes as well as glucose uptake to see where portions of your body you may have a higher cellular metabolism to kind of view where these things are. So it says staging may require CT scan or MRI. And that's just, it may, I mean, there's sometimes when they may go in, and you'll hear this story a lot in terms of, you're like, oh, a patient went in and they went to have some sort of, maybe a hernia repair, and then they find a mass, and then while they're in there looking at it, they're able to say, okay, what about the local lymph nodes, things like that, and then they can start their staging process from there, but it does depend on the type of cancer. So jumping down to pharyngitis, we talked a little bit about this in our story. So this is inflammation slash infection of the throat. So you do want to rule out strep. Nursing assessment, sore throat, dysphagia, same. White patches in the pharynx. How do we diagnose this? Huh? Said.
No, it's got a swab.
Yeah, we might do a swab. Some doctors may just treat you under clinical symptoms, but typically we do want to rule out strep because it's an infectious agent, right? So esophagus, nursing assessment of the esophagus, pain, dysphagia, weight loss, regurgitation, halitosis, cough. What's halitosis?
That's
And what do we mean by regurgitation? And that can be like full-on emesis, that can be belching with stomach contents, which occurs. Halitosis is good because I can tell you about any sort of infection that may be going. But again, all these are kind of vague, right? Because we hear a lot of people are like, I think I'm having trouble swallowing. Yes?
The regurgitation, is it usually happen after eating or just?
Depends if we're talking about something like dumping syndrome, hiatal hernias are actually like kind of mechanically obstructing masses. And you can have people who, maybe it's just like, oh, if I eat too fast, or if I eat a certain type of thing, or if it's a certain type of consistency. One of the subtleties, and I think people take like gerontology for granted because it's a field of subtlety where you can have a patient who has something like this that develops slowly over time. So slowly, in fact, that they will modify the way and what they eat without them really noticing that they're doing it. Like, it can get to the point where it's like, oh, every time I have this, I have like X response, I have more heartburn, or I tend to have trouble getting it down. And they may just attribute this to like an age-related change versus, and then suddenly they come in and they're like, yeah, mom just always eats mashed potatoes and soup. And they're like, is that all she likes? Yeah, that's all she likes. Okay. Find something in there. So here we're talking about hernias as well. Why am I mentioning hernias when I'm talking about the esophagus? Where do hernias occur? Who said we could spend minutes? So, hernias can occur in different places. Let's think about your average person who's like, oh, a hernia. Oh my God, where is it usually? Right here, right? Like you're kind of laying there and you're like, oh my God, is that thing in the top? But hernias can occur at your diaphragm. Okay? So they can go up, you can have this hernia occur around, you have hiatal hernia, which can cause a lot of problems. And most people, well, a lot of people won't know that they're there. They just think, oh, I GERD. It's not really GERD. Pyrosis, which is a fancy word for heartburn that I've never heard in my life. So, I've looked at heartburn. Regurgitation, dysphagia. Are you seeing a pattern here? Fullness after eating, which I don't know. Okay.
So I'm looking at you.
Huh?
Looking at you, no. I'm really sorry, guys.
hoarseness, wheezing. Now, we talked a little bit in respiratory about signs of aspiration. And can patients chronically aspirate?
Yes.
So, what do we think about patients who chronically aspirate?
Well, is it sort of like a blockage or something? Is that what you're kind of meaning that?
Maybe. If you have a patient who comes in, we'll do a super fast flashback. If you have a patient who comes in and they're like, I have chronic bronchitis. What do you think? You think they actually have chronic bronchitis? They got chronic aspiration, right? What's something that can cause chronic aspiration? Yeah, you can have a neurogenic problem, right? You can have an obstruction, you can have a cancer. So that's one thing, if you have a patient who comes in, they're going to see their geriatrician, say, and they're like, oh, I feel like I choke on food all the time. Or they come in and say, hey, I feel like I get, I just keep getting these upper respiratory infections. And the physician might go, well, how are you eating? How are you swallowing? Let's look this up and see if there's some sort of issue going on, right? Disorders of the esophagus, cancer of the esophagus. These patients have it tough, real tough. So esophageal cancers are rare and they have a poor prognosis. And this is something I want to drive home, is that you're going to have a patient, you will see patients who have just been diagnosed with cancer and they look great. Like they may even be like post-surgery, post-chemo, post-radiation, and they look great. The one thing that you should keep in the back of your mind is that once you hit this diagnosis, you enter a statistical bell curve, how long you're going to live. No matter how good you look, you enter the bell curve of how long you're going to live. There are always outliers. Some people respond better to certain treatments than others. You have certain types of cancer that are separated into very specific typing that will respond to a very, very specific gene-centered therapy. And then you have others like triple-negative breast cancer where nothing will happen. When we talk about brain tumors, we have things like astrocytomas, oligodendrocytomas, and you're like, okay, we can kind of work with this. But when you come in and you have a stage 4 glioblastoma multiform, you know that you have 12 months left. Regardless of how good you look right now, you have 12 months left. So, there's a couple different types, squamous cell cancers and adenocarcinomas, and then Barrett's esophagus, which we'll talk a little bit about. And you can see here in this picture, you have the normal lower esophagus and the Barrett's mucosa. This is actually something, bless you, something I've come to appreciate more now that we use the iris for feeding tube placements. Is anyone familiar with that? So it's like I think small bore Dom Hoff that goes down the nose with a camera, so I can see what I'm looking at, which is great because if I'm paying attention, I can tell if I'm in the lung fairly immediately. But I can also get a view of the esophagus, and once you kind of get to, which I think of it as like a mini EGD, because you get to kind of look around sometimes, you really get to appreciate the difference between a normal GI tract and one that has been badly damaged. Especially when you see someone who has like portal hypertension. As soon as you get down into the gastric body, you just see inflamed vasculature everywhere. It's kind of neat. So risk factors for esophageal cancer, GERD, Barrett's esophagitis, hiatal hernias, and it's more common in men. I think every patient I've ever seen that has esophageal cancer was a man. African Americans, higher rates in China, and we'll talk about demographic-specific incidences because it is important. Like where I work, we know who's at risk for certain diseases. For instance, I would say, this is anecdotal, I'd say 70% of our aneurysms come from Alaska. almost all of our Moya Moya patients are Japanese in origin, but it's also very interesting when you start to play, when you start to think, and you're kind of playing a mind game when you think about the kind of way people from certain areas disperse out. So like now, even though that, like when you look in a textbook and say, Moya Moya occurs in this population, but we've seen that, and it was just typically Japanese, they tend to come into Alaska and into the Pacific Northwest. So now we're starting to see these incidences occur in other populations that we didn't expect, that weren't high-risk populations before. Anyway, smoking, alcohol, diet, and this is all. Welcome back.
I won't interrupt too much, but I'm gonna pass some stuff out. You don't need any names, just look for feedback.
So nursing assessment for esophageal cancer and maybe asymptomatic for a long time. We kind of covered that. These things are typically not good when they're found, which is why it's very important to be proactive with your health. Your dysphagia will become progressively worse as whatever, if it's a cancer or a tumor, gets worse. You can have this substernal pain, regurgitation, weight loss, anorexia. Again, see the pattern? GI bleeding and anemia. So this is actually a really good note. You can have bleeding tumors. You can have varices. You can have esophageal varices. And these patients can become anemic, and it can be easy to look at a patient who, let's say, they're a drinker, and we're like, they come in and do their labs, everything's kind of low, and you're like, oh, it's because you're a drinker, right? But they may have bleeding varices, they may have something else going on, so it's important that you thoroughly assess these patients. So looking more at esophageal disorders, echolalia is something I want you to know. And this involves the esophagus and the dilation or the widening of the esophagus. And the point of that being, if you can see here, see how this sphincter kind of begins to constrict and not work very well. This is something you will fairly commonly see. And these patients may have to go in and have a dilation done. I've seen people who have to get dilated every few years. I actually took care of a patient who had the longest known functioning esophageal stent, because they normally fail after a certain period of time, like any medical device can. And he actually, I don't want to put the dirt sheet, but there was like a team of Japanese doctors that would come and study him, like every few years. And here you can see the diverticulum. Now, we're talking specifically about the upper airway right now. You can have these diverticulum that form in the upper airway, but you also have diverticulum that form in the lower, in the upper GI, but also in the lower GI, right? So these diverticulum can create a pocket. Typically when we think of diverticulum, we often think of the lower gut. And this idea, which is, I believe is still tested, is tested formally, that things like nuts and seeds and stuff can get caught in and can cause inflammation. And we'll get that when we talk about actual diverticulitis, diverticulosis. But the point in this is to see that this essential pseudo pouch can create, and you can have food that gets trapped in there. And there's not a whole lot you can do about it. Yes?
How did this happen in the first place?
Misfortune. I couldn't tell you everything. How long have we been going with this? Do we need 5 minutes?
Yeah.
Okay, 5 minutes, firm. We don't have much time, we still have a lot to go.